So my topic today is travel medicine. My name is Christina Ayarza. I'm one of the infectious disease fellows at University of South Florida. We're going to be talking a little bit about what travel medicine as a subspecialty is today. We'll talk about immunizations. We won't go into that much details because Dr. Damis has that topic next week. We'll talk about travel diarrhea, its prophylaxis and the treatment in the traveler. We'll talk about malaria and prevention of some non-infectious disease in the traveler. We'll just go over a little bit about fevers in the returning traveler, but that's not the main focus of this. And we'll have some pictures at the end. Travel medicine is a specialty. It's dedicated in the prevention of infectious disease during travel and personal safety of the traveler and the avoidance of environmental risk. So most of travel medicine care should be performed in a specialized travel clinic by a person who has training in the field, and especially if the traveler has a complex itinerary. And the primary care physicians and non-specialists should have some basic knowledge in this area. They should be able to give advice to the traveler who is in good health and is visiting low-risk destinations. They should have an understanding of indications of vaccines and the procedure involved in this. And they should also have some knowledge in the prevention and management of non-infection traveling health risk. And they should recognize the major syndromes in the returning traveler, like fevers, diarrhea, or rash. It's the discipline of travel medicine has grown in the last 25 years with the development of the founding in the International Society of Travel Medicine in 1991. They already have 2 journals dedicated to travel medicine. The Journal of Travel Medicine, founded in 1994, and the Travel Medicine and Infectious Disease in 2003. Factors contributing to making travel medicine a specialty has been the increase in traveler number. In 1990, it has doubled. In 2004, from 400 million to around 700 million travelers. The changing in the epidemiology of travel illness, the growth in the vaccinology field, and also the awareness of prevention of illness is not the only thing that is not only limited to vaccines and chemoprophylaxis. There's guidelines published in the IDSA in 2006, which usually concentrates in the 3 biggest areas, which are vaccines, management of travel diarrhea, and prevention of malaria. And I used a lot of this publication to do this presentation. And definite US practitioners should use the yellow book. That's the main book for travel medicine. The provider should have certain qualifications to provide care in travel medicine, and it's based on these 3 main categories: knowledge, experience, and continuing education. In the knowledge, they should know about the geography of where people are traveling, the illness associated to these places, including epidemiology, transmission, and prevention. They should know about vaccines, how they're stored, how their indications, their contraindications, and their adverse events. They should also know about non-infectious travel risks. We're talking about DVTs, accidents, and everything that's not related to an infection. They should recognize the major syndromes, and they should have access to travel medicine resources. In experience is how many patients they see in their clinic, either weekly or monthly. They should not be seeing only 1 patient a month. They should have at least a couple a week. And they should also have continuing education. This can be either by short or long course in travel medicine. They should be members of the specialty society, and they should be members of the journals. The service they provide, they should assess the health of the traveler, meaning they should know their medical conditions, their medications, their allergies. They should have their immunizations up to date in their records. They should investigate the itinerary, know what season they're traveling, how long they're going to be traveling, the reason why they're traveling, if it's business or just for pleasure, or if they're going to be doing any extracurricular activity, as well as what type of things they're going to be doing, if they're going to be staying in a hotel or staying in rural areas. They should also provide prevention advice, and this should cover all of these areas, which are vaccines, travel diarrhea prevention and self-treatment, malaria prevention, insect avoidance measurements, other mosquitoes, vector-borne illness. They should talk about safety, behavior, and sexual health. They should talk about what type of environment they're going to be in, the altitude, heat, cold, swimming, or diving. They should talk about motion sickness, jet lag, animal bites, how to avoid them, and how to treatment, what to do when it happens. If they're going for a long-term traveler, they should also include special measures. They should focus on special travelers like pregnant, older, immunocompromised patients. They should tell the traveler where they can get information if something happens at that place or before going, and how to access the medical care where they're going to be at. This is an example of how the documentation should be done at the travel clinic. You should have all the demographics of the patient. You should have all the past medical history, their past travel history, their immunizations. You should write down what immunizations you did that day, what advice you gave that day, and what medications you provided for their travel. The immunizations, this is from the Mendel. These are divided in two groups: vaccines to consider for everyday destination or vaccines to consider for selected destinations. We'll talk about them separately. So the main thing is, to all destinations, they should have hepatitis A, B, the typhoid, and the influenza and varicella. For selected destinations, you can do yellow fever, meningococcus, rabies, Japanese encephalitis vaccines, polio, cholera, or tick-borne encephalitis vaccine. Everyone should have their routine adult immunizations up to date. That means they should have their Tdap at, every 10 years, or once. Sorry. TD, yeah, Tdap once, at least in the past 10 years, but TD every 10 years. If they were born before 1957, they're considered immune to measles. If they don't have any evidence of varicella immunity, they should get the 2-dose vaccine, and they're considered immune if they were born before 1980. For hepatitis A, it's indicated in every traveler if they're going outside any developed country like the US, New Zealand, Scandinavia, Canada, or Japan. The CDC recommends an ancillary concomitant immune globulin for travelers if they're older than 40 who are planning to depart in less than 2 weeks and they get the vaccine, but this is not practiced as much. A single dose prior to departure will confer protection, and once you have the 2 doses, you don't need it ever again. You don't need a booster. You can offer hepatitis A and B. It's available for people that are older than 18. And there's also accelerated vaccines for this available that you can get within a month at day 0, 7, and 21. The typhoid vaccine, there's 1 to 10 cases per 100,000 travelers, depending on their destination, may get typhoid. It's recommended to travelers that are going to Central or South America, Asia, Africa, who will be consuming food or water in areas of poor sanitation and hygiene. So usually the subtropics and tropical areas. There are 2 vaccines available, and they protect only against Salmonella typhi in the US. They don't protect against Salmonella paratyphi. The first vaccine is the live attenuated oral vaccine, which is the Vivotif. And then there's an injectable capsular polysaccharide vaccine. They're both similar in efficacy. They only protect 53 to 72% protection. And for the oral, you'll need a booster in 5 years. For the IM, you'll need a booster in 2 years if you're going to be in that area of endemicity. The onset of protection is usually at 1 week after the dose, and it's not recommended in pregnancy. and it should be avoided in immunocompromised patients. The oral vaccine should not be given together with either anti-malaria or antibiotics, which you take 2 weeks prior to departure, because this decreases the efficacy of the vaccine. There's a concern with the recent quinolone-resistant Salmonella typhi in Asia, and again, it doesn't protect against Salmonella paratyphi, so you should always do prevention, not drinking the water or eating the food in this type of places. For yellow fever, the vaccine is regulated by the CDC and the state health department. There's a special certificate that you need sometimes to get into certain countries, and there's also special needs for the storage of it and the administration, because there's some anaphylactic reaction reported with this vaccine. The endemic zones usually lie in the equatorial South America and around 15 degrees on either side of the equator in Africa. And the CDC estimates that only 10 to 30% of Americans traveling to endemic areas have been immunized. From 1970 to 2010, a total of 9 cases of yellow fever were reported in unvaccinated travelers in the US and Europe. 8 out of 9 died. Only 1 case was documented in a vaccinated traveler. The vaccine, it's a single dose live attenuated vaccine. It's highly effective, and it should have a boost. It should be administered at least 10 days before travel, and a booster every 10 years for the international travelers. There has been recent report of viscerotropy and neurological disease reported with the vaccine, and it's believed to be secondary to an altered host response to the vaccine. And it's seen more when they did the studies in those patients. There were higher incidence of like thymic function and thymectomy on these patients, and usually they were older, so right now the vaccine is not recommended in these populations. The principal vector is the Aedes mosquito, and a number of African countries and 1 in South America, French Guinea, require proof of yellow fever vaccine for all arriving travelers. And this is because they have the vector, but they're not endemic, so they don't want to create an epidemic. Contraindications for the yellow fever would be allergy to the component, less than 6 months old, symptomatic HIV or CD4 count less than 200, thymus disorder or abnormal immune cell deficiency, malignant, just any cancer, transplant, or immunosuppressed. You should be cautious in ages 6 to 8 months, ages above 60, asymptomatic HIV with CD4 count between 200 and 499, pregnancy and breastfeeding. These are the areas where the yellow fever vaccine is recommended, mostly the yellow areas in Africa and South America. The meningococcal vaccine is required in Saudi Arabia for religious pilgrims traveling to the Mecca for the purpose of Hajj or Umrah. It's recommended in the meningitis belt in the sub-Sahara of Africa, from Senegal to Ethiopia, especially if they're traveling between December and June. Areas of epidemics, you can track it down with the CDC or the World Health Organization webpage. And there's investigation going on for Guillain-Barré associated after getting the vaccine. For rabies, it's recommended to travelers that are going to endemic areas who will have occupational or recreational exposure, like veterinaries, spelunkers, or with animal contact. The cases are rare, but bites are not. So most common bites are from dogs. Others could be monkeys, bats, mongoose, or foxes. You should give a lot of education to avoid dog bites. And if they're bitten, they should clean it with water and soap and get appropriate prophylaxis. The pre-travel vaccination will eliminate the need for post-exposure immunoglobulin if a bite occurs. So all travelers who have an exposure to a bite, no matter their prior vaccination history, they need post-exposure prophylaxis. It just depends if they'll need the immunoglobulin or not. For Japanese encephalitis virus, it's a mosquito-borne viral disease prevalent in Asia and in some islands in the Western Pacific and in the island of Torres in Australia. Pigs are an important reservoir, but the rice fields are common breeding sites. The risk is low in the traveler unless they're going to go to these rural areas. From 1973 to 2008, there were 55 published reports of travel-associated Japanese encephalitis from non-endemic areas. The decision to vaccinate depends on the season, more if it's summer through fall, and what destination they're going to go to. And who should get it? The traveler that's going to be in the area for a long time or for a short time in the rural area near these places. And if they're going to be hiking, biking, or in the field work. There is an inactivated viral cell culture derived vaccine that was approved in 2009. It's usually 2 doses at day 0 and day 28, and it should be completed 1 week before travel. And there's no studies of how long it protects. They just have studies up to 24 months. So after that, we don't know if they need a booster or not. This is the area where the Japanese encephalitis virus is endemic. The cholera vaccine is no longer required by any country. The risk for a typical traveler is very low. It may be considered in medical and aid workers staying for short periods in a disaster area or refugee camp, and you may consider the vaccine at this point. Acute diarrheal disease, it can kill within hours, usually gives you a lot of dehydration. There's around 5 million cholera cases and around 100,000 deaths due to this every year. Up to 80% of the cases can be treated with hydration. Provision of safe water and sanitation is the critical part for this. 2 types of safe and effective oral cholera vaccines are available. They were both whole cell killed vaccines, one with a recombinant B subunit, the other without. Both vaccines are administered in 2 doses, given between 7 days and 6 weeks apart. These are some areas in 2010, 2011 where outbreaks were reported. Some in Haiti, Republic Dominican, South Africa, and India. Tick-borne encephalitis, it's an emerging important flavivirus CNS infection in endemic areas. It's prevalent more in rural forest areas in Eastern and Central Europe, Scandinavia, and Siberia in the spring and the summer. It's transmitted by the Ixodes tick. It may be transmitted by unpasteurized dairy products in the endemic areas. There are 2 inactivated vaccines. They're not approved in the US or Canada, and they need 3 doses within a year. And those are the 2 vaccines available. They should always practice tick precautions, wearing the appropriate clothes, repellents, resistant insecticides, and checking for ticks. For the polio vaccine, polio remains endemic in 3 countries, Afghanistan, Nigeria, and Pakistan. It has been re-established transmission in 3 other countries, which were previous polio-free, like Angola, Chad, and Democratic Republic of the Congo. And the World Health Organization considers a single confirmed case of polio paralysis to be evidence of an epidemic, particularly in countries where very few cases occur. And these are right now the endemic areas of polio in 2012. This is more of a picture of all the infections we've been talking about where they're endemic at. This is more in 2006, 2007 from the Mendel. Immunizations. So a little bit, if the traveler is uncertain of their immunizations, we should make all efforts to obtain the records. If not, we should check serology. In Saudi Arabia, they require the meningococcal vaccines to all pilgrims visiting the country. If there's an anaphylactic reaction to egg, you should not give the yellow fever, influenza, or MMR vaccines. Live viral vaccines should not be given simultaneously or at 4 weeks intervals to avoid immune interference. They should be given at the same time. If not, you should wait 4 weeks. That's what I meant. Vaccines should be delayed until a person recovers from a moderate to severe illness. The immune serum globulin may be used occasionally for hepatitis A prevention, and it should not be administered less than 3 months or before 2 weeks after MMR or varicella vaccine. An interrupted course of vaccination does not require restarting the course, except in the oral typhoid vaccine. It doesn't matter how long it's been. The next topic is traveler's diarrhea. This is defined as more than 3 loose stools over 24 hours, accompanied by either fever, nausea, vomiting, or abdominal pain. It usually resolves within 3 to 5 days. 1/4 will need to change their itinerary of their travel, and few will have post-diarrhea irritable bowel syndrome. 40 to 60% of persons traveling for a period of 2 to 3 weeks will have a syndrome of traveler's diarrhea. The most common causes are E. coli, Salmonella, Campylobacter, Shigella, most common being E-tech. Less common are non-cholera, Vibrio, Aeromonas, Plesiomonas. Some viral causes to consider are norovirus and rotavirus. Norovirus we've heard in the cruise ships. Parasites to consider, and this is more when they stay for a long time in endemic places: Giardia, Cryptosporidium, Cyclospora, and Entamoeba. They're less common. Contaminated water accounts more for viruses and parasites. For prevention of traveler's diarrhea, most common way of getting it is through food or water. So you should avoid tap water, ice cubes, fruit juice, fresh salads, unpasteurized dairy products, cold sauce and toppings, open buffets, undercooked or reheated foods.
Everything's gonna be hot.
Yes. There's no vaccines available. The inactivated oral Vibrio cholera confers limited protection and it's not available in the US. There's chemoprophylaxis available. In the recent year, it's been more of a debate because of increased resistance. You can use bismuth subsalicylate formulations. It can give you protection in 60% of the cases. There's antibiotics that have been proven effective in preventing traveler's diarrhea, and these are the ones that they've used in the studies: norfloxacin, ciprofloxacin, and rifaximin. Concerns for resistance is arising. There's also a concern of acquiring other pathogens like getting C. diff infections. Currently, the FDA doesn't approve any of the antibiotics for prophylaxis. The treatment would be fluid resuscitation, symptomatic treatment, and antibiotics. For symptomatic treatment, something like Pepto would help. You can also use loperamide for an antimotility agent. It's not recommended if you have fevers of more than 38.5 or blood in the stool. It's not recommended in children either. And probiotics have not been proven to be helpful. For antibiotics, you can give usually a 1-day course to a 3-day course. If by the end of 24 hours the symptoms have resolved or improved to the point where they're functional, you could stop them. They don't recommend anymore to use antibiotics like Bactrim, neomycin, ampicillin, doxy, or tetracycline because of resistance. There's increased resistance to Campylobacter to fluoroquinolones out there, and this has been described in Asia and India. An alternative to these antibiotics would be azithromycin, and it's safe in pregnant women, it's safe in children. It covers Campylobacter and other enteric pathogens. Another alternative for fluoroquinolones would be rifaximin. It's good because it doesn't get absorbed. Most of it has limited absorption. It has a good safety record and activity against many of the pathogens. And I already said duration 1 to 3 days depending on how they respond to it. This is just a table saying the same thing, the doses and what antibiotics you can use. The prevention of malaria. Malaria is the most common preventable infectious cause of death in the returning traveler. Around 1,300 cases are reported every year, and mostly because they don't take the chemoprophylaxis or they don't use it correctly. Usually they talk about the ABCD of malaria prevention, which is awareness, bite avoidance, compliance, and prompt diagnosis. The most clinically severe disease is from the falciparum species, and so the most effort is to prevent this one. Risk assessment requires a detailed itinerary of the traveler. It depends on the geographic area, type of accommodation, duration of stay, season, and how elevation they're gonna have at their travel. So people should avoid mosquito bites at dusk and dawn. They should use mosquito repellent containing DEET. They should have well-screened or air conditioning rooms. They should have insecticides impregnated bed nests if they're sleeping under one. And they should wear appropriate clothing. Questions to address before starting chemoprophylaxis would be, are they at risk? Are they going to an area where it's endemic? And if there is resistance to in that area, will the traveler have access to medical care? And in the event they get symptoms, are there any contraindications for the drugs? These are endemic areas. This is from 2008. Endemic areas of malaria, usually in the same pattern, tropical. The chemoprophylaxis, if you're going to an urban and rural risk area in the sub-Saharan Africa, except in the most of the south. If you're going to Oceania, including Papua New Guinea, India, except Dhaka, Pakistan, Nepal, Haiti. Travelers with overnight or evening exposure in rural, non-resort areas in the South Asia, Central and South America, and certain parts of Mexico, North Africa, and Dominican Republic. They should get chemoprophylaxis. Chloroquine resistant is widespread in the world in endemic areas except in Mexico, Haiti, Republican Dominican, Central America, west and north of the Panama Canal, and parts of North Africa, Middle East, and China. MDR resistance, which implies chloroquine, mefloquine, and sulfonamides resistance, are confined to areas of Thailand that are bordered by Burma and Cambodia, Eastern Province of Burma, and Western Province of Cambodia. Chloroquine resistant Plasmodium vivax is widespread in Papua and Papua New Guinea, and it's documented in other areas like Colombia and Guyana. Anti-malarial drug will not guarantee protection even if you take it correctly against this malaria. Travelers should be aware that fever during or after travel up to 1 year after returning from endemic areas is a medical emergency and it requires urgent assessment. They should have a thick and thin blood films, and they should be repeated twice within 12 to 24 hours if the first one is negative. Long-stay travelers should be aware that some laboratories in endemic areas, like in Africa, have a high incidence of false positive rate in the malaria diagnosis. This is the endemic areas. The dark red is, can't see. chloroquine resistance. Yes, the pink area is chloroquine susceptible, and white areas are not endemic areas. And the same in the area of Africa and South Asia, Middle East. We can see it here. So red, chloroquine resistance. We'll talk about how to treat them. The drugs we use are chloroquine, and this is the drug of choice in endemic areas where there's no reported or low incidence of resistance. It's usually well tolerated with exception of the bitter taste. It may cause non-allergic generalized pruritus, more in African American, and it's safe in pregnancy. The other drug, we have Malarone, which is atovaquone proguanil. It's one of the 3 drugs available for areas with chloroquine resistance. The other 2 would be doxycycline and mefloquine. Atovaquone, it inhibits the parasite mitochondrial electron transport, and it can act synergistically with proguanil, usually in the susceptible and resistant, even in the MDRs of Plasmodium falciparum. It does not prevent malaria from the formation of hypnozoite by Plasmodium vivax and ovale. The drug is taken one pill. It usually starts 1 to 2 days prior to travel. During exposure you take it, and 1 week after returning from exposure. It has excellent safety profile. It's well tolerated. Most common side effects would be GI, insomnia, headache, rash, and mouth ulcers. And it's contraindicated in renal insufficiency and if they have less than 30 of creatinine clearance. It's not recommended in pregnancy. Mefloquine, it's effective in preventing disease in all species except the multi-drug resistant Plasmodium falciparum. It's well tolerated. Its most recognized side effect would be neuropsychiatric, and it's one of the main reasons for the drug to be discontinued or not started. Usually you'll see the psychiatric symptoms within the first 3 doses, so you can try starting the drugs before they go into the place in case they need to be changed. It's contraindicated if there's hypersensitivity, if they had a history of convulsion or a major psychiatric disorder, if they were treated for depression or anxiety recently, and it should be used in caution in patients with cardiac conduction disorders. Not recommended in pregnancy. And if the patient is departing on a short notice, you may give a loading dose of 250 milligrams PO daily for 3 days, followed by weekly administration. This is off-label. Doxycycline is effective in preventing all species of malaria, including the multi-drug resistant. You usually start at 1 to 2 days before exposure, during exposure, and you have to continue the drug 4 weeks after exposure. It's well tolerated. Usually side effects are upset stomach. You can get the photosensitivity reaction due to ultraviolet radiation, and also you can get candida vaginitis. People that are at risk would be someone like with diabetes. You may consider telling them to take treatment for the trip. It's contraindicated in pregnant women and in children less than 8 years old. And the disadvantage is, it's a daily dose. People may forget to take it. Alternative medications, primaquine it's been used for decades to prevent relapse from hypnozoite from the Plasmodium vivax and ovale. It's safe and effective, but only in individuals who have normal G6PD, so you need a test before starting it. It's effective against chloroquine resistant falciparum. It should be started 1 day before exposure, during exposure, and 7 days after exposure. Most common side effect would be GI intolerance, and the disadvantage is that you need the G6PD testing prior to starting the drug, and it's contraindicated in pregnancy. Tafenoquine is an investigational drug. It's not out there. It's not available. And has the same problem as primaquine. You need G6PD, but you may be able to take it only once a week or once a month. So that's why they're looking into that. I don't know if it's still out there. This is a table making reference to all the drugs we just mentioned. And this is a table that will help you guide if there's chloroquine resistance or not, if there's MDR, and what drug they should be on, depending on the geographic. Usually you have to refer to the CDC or the WHO webpage to know the current places where it's endemic. So other recommendations for the traveler, they should be giving guidelines as how to locate reliable care where they're going. They should be encouraged to take travel health and evacuation insurance. You should talk about injuries because this is the leading cause of death among travelers. You should talk about unprotected sex and the risk for HIV, hepatitis B, hepatitis C. They should use barrier protection, and they should know that it's not 100% protection versus abstinence. They should all wear, sunscreen, and if they're going to be exposed to the sun for a long time, they should reapply every 2 hours. For motion sickness, you can recommend scopolamine, either transdermal or oral, and other things you may use, meclizine. You should talk about jet lag, usually when the circadian rhythm is interrupted, and there's studies showing that either short-acting hypnotic like benzos, like zolpidem, or melatonin may work. And they should try these medications before going over there to make sure that they can tolerate them. You should talk about sensible measures to avoid DVTs, which include avoiding prolonged immobility, not wearing constrictive clothing around the waist or the lower extremities, exercising the calf muscle, maintaining hydration, avoiding alcohol, and below the knee support stocking. You should talk about high altitude. There's an issue because there can be 3 clinical syndromes if you go above 8,200 to 11,000 feet of altitude. The 3 most clinical syndromes are acute mountain sickness, where they get headache, they get fatigue, dizziness, and sleep disturbance. They can get high altitude cerebral edema, which they get poor concentration, lethargy, even coma and death because of herniation. And then the 3rd syndrome is high altitude pulmonary edema, which you can have dry cough, shortness of breath, frothy pink sputum. So they need to be aware that the best way to avoid this is by acclimatization, where you spend a couple of days at certain height before you go to higher altitudes. I can't see the rest in mine.
Can you see it over there?
No. It's cut off, sorry. So it says to spend a few days in an intermediate altitude less than 3,000 meters and then go gradually. No, it's cut off, it's black. And then every night you should go 300 to 500 meters per night until you get to your destination. Post-travel care. Think of the area of travel to identify any possible etiologies of fevers. Plasmodium falciparum malaria usually originates from the sub-Saharan Africa, particularly in the West Africa. You can get rickettsial illness, like African tick bite fever from Southern Africa, dengue more in the Caribbean and Southeast Asia, cutaneous leishmaniasis from Central and South America, typhoid fever if they've been in South Asia. Febrile illness that warrants immediate attention would be malaria. Every returning traveler who has a fever, they should be evaluated for malaria if they were in endemic areas. Other syndromes to consider would be dengue, acute HIV syndrome, leptospirosis, acute schistosomiasis, enteric fever caused by Salmonella typhi or Salmonella paratyphi. Skin problems may present as a discrete lesions like cutaneous leishmaniasis, cutaneous larva migrans, tungiasis, myiasis, pyoderma following an insect bite. Skin infections can also be a systemic manifestation, like you may get an egg scar from the African tick typhus caused by the Rickettsia africa. You may get a chancre that can indicate East African trypanosomiasis. Systemic rashes may be seen in dengue, chikungunya, acute HIV and measles, and respiratory illness. You should consider TB, influenza, pneumococcal, and the avian flu. These are some pictures. I have the answers here. So A, it's a painless ulcer with clean base in the traveler to Peru. Cutaneous leishmaniasis due to Leishmania brasilensis. Where's Luis? B would be a picture B is a nodular and inflammatory lesion with crusting and its slight ulceration in a traveler to Afghanistan. Cutaneous leishmaniasis due to Leishmania major. C is a painless nasal perforation. That's in the differential. So, let's say Peru. It's the early manifestation of mucocutaneous leishmaniasis due to the metastatic spread of Leishmania brasilensis. No. D, it's cutaneous larva migrans. E is a furuncular. Yes, myiasis. And the patient reports a sense of movement inside. And there's a tiny hole where they can breathe at. G, it's a multi-lesion presentation, travel to Africa. It's myiasis, it's the tumbu fly. Right. H is a phytophotodermatitis in a traveler to Ecuador after applying lime juice containing mixture in a native ceremony. Yeah, I'm telling you the answer. And I is tropical pyomyositis in a traveler to the Amazon due to staph. A, he went to Puerto Rico. Dengue. B, hemorrhagic fever. C, you can't see? He has bulle, yeah, in all the skin, so it's vibrio vulnificans after ingesting shellfish. D, it's a migratory lesion after ingesting uncooked freshwater fish. Oh, I can't pronounce it. It's Natotoma. Yes. Natotoma spinningerum. That one. Natostoma. That sounds nicer. E is a faint papular rash, pruritic, after travel to Sierra Leona. It's E. Oh, I have something. That one. Oh, you can't see much of it. Can you turn the light off, please? But they're better. That's better. So, no. Faint papular rash, pruritic. Travel to Sierra Leona. It's Onchocerca volvulus. Let me see. F. Escar. It's African tick typhus, yeah. Rickettsia africa. G is a verruga piranha. And then I is a spider bite due to Loxosceles later. Loxosceles, yeah, later. Okay. No, these are tables for reference. That was pretty much it. Me too. No, these are tables that you can use for reference um, for the returning traveler with a fever. But this is not my topic. I think Dr. Araba had that topic in the past.